So welcome everybody, wherever you are dialing in from or joining from. My name is Annie McCluskey. I'm an occupational therapist and an implementation science researcher and a member of the StrokeEd collaboration here in Eastern Australia. Jake McMahon is joining me today. He's a registered nurse and a PhD candidate at the Australian Catholic University and the NHMRC Centre of Research Excellence in Wiser Wound Care. He also works at St Vincent's Hospital in Melbourne. We have health professionals joining us today from a lot of people from Australia and New Zealand, from the United Kingdom and Ireland, but we also have people from far afield, from Myanmar, Iraq, the Democratic Republic of Congo, Togo, Singapore, Ethiopia, and within Europe, we have people from Germany, France, Spain, Denmark, and also from Saudi Arabia. So welcome to you all, at whatever time it is. I would like to acknowledge the traditional custodians of the lands on which Jake and I are working today and pay our respects to First Nations elders past and present. Now, this lecture series, this is the third in a series of 5 lectures about de-implementation. And Jake's going to be telling us about the definition and the meaning of de-implementation. It's intended to make you think and encourage you to talk with your colleagues and your managers and people that you work with. We want you to think about how you use your time at work, particularly that valuable, scarce resource, time that you have one-to-one with patients or clients. I've done several implementation studies, including one study looking at increasing the use of constraint-induced movement therapy. And I've used interventions, behavior change interventions, such as audit and feedback, reminders, and workshops to train people in the skills and knowledge that they need to implement a new treatment. But de-implementation is relatively new to me. So I'm going to give you my short take on the topic, and then Jake can correct me if there's anything that I have misinterpreted. My reading of de-implementation is that it's the cessation or the removal or the abandonment, which is a fairly big word, abandoning routinely provided treatments that have been found to be ineffective or in some cases harmful, but that's fairly unusual in rehabilitation. And low-value care that we'll hear more about today is treatments or therapies that are either not supported by evidence or where there may be evidence of no benefit for patients and clients that we work with. More often, we have treatments that are better than one another. So in the case of Bobath that you'll hear Simone Dorsch talking about next week, and Zheng Chao, we have evidence from 2 systematic reviews next week that we'll hear about, where task-specific training is recommended in our guidelines as a treatment that we should be using, and it's superior to Bobath therapy. And that means that we have to help therapists and departments to change the way that they operate. And it may mean changes in the way that people attend continuing education. We also have evidence presented last week by Laura Jolliffe that hand splinting done routinely is not an effective treatment for preventing contractures, preventing spasticity. Really, it has no effect on any outcomes. So we need to find other treatments such as mental practice, mirror therapy, electrical stimulation that may help the muscles to start contracting. So next week you have another lecture about implementing mental practice to help you on that road. So Jake's going to be talking for a little less than half an hour, and you'll have opportunities for questions along the way. Use the Q&A option down the bottom of your screen. You won't be able to use the chat. We will stop along the way, and there's going to be plenty of time at the end for questions and clarification and comments. We don't provide any handouts or certificates of attendance for these free lectures, and the recording will be available in about a week on our website under the resources tab at the top of the screen on our homepage. So I'm going to pass over now to Jake. Thank you, Jake.
Thanks, Annie. And I think you nailed the definitions, so I don't know what I'm doing here. But thank you for asking me to speak today, and especially thank you to everyone who has made the effort to be here today. My name's Jake McMahon. I am a nurse and a PhD candidate. I'm completing a PhD with a focus on de-implementing low-value practices in health services. And my area is more specifically around pressure injury prevention and management, but I will make this more generalizable to nursing and allied health. And I just wanted to say I'm not an expert in de-implementation, and there's probably some people in the audience with greater expertise. But when I designed this, I thought I'd do so at an introductory level. So if I'm telling you something that you already know, please feel free to put some more information in the chat, but I'm hoping there's going to be something in here for everyone. And as I said, I'm no expert, but I am a PhD candidate, which means I spend half my life reading about de-implementation. So hopefully I can translate some of the readings that I've done so you don't have to do as much reading as me. And I've just put my Twitter and my email on just up on this slide here. So if anyone wants to reach out and has a question that they're not comfortable with sharing or think at a later stage, just let me know. So I'll run through what I'm hoping to do tonight or today, depending where you are in the world. I'll run through some common terms seen in the literature and what definitions I like and have helped me. I think it's important to know what we're talking about before we go into it. I'll go a bit into the background on why it's an important area of health research, what's driving low value practices, and then some theories and frameworks that I've seen and I like. And then I'll try and tie some examples throughout the lecture and give you some key resources and further readings that have helped me when I first started really inquiring into this area. And as these points that I want to cover are all quite large, we'll only really scratch the surface, but I'm hoping it will be a good starting point. And I've seen some of the other lectures in this series and some of them that are up and coming. And I think this probably might be a really good introductory that really helps you understand why some researchers have made certain decisions about designing their projects and conducting their research in certain ways. So before we go into the lecture, there's a few terms we should define. Like I said, I think it's important that we understand definitions as it helps us all be on the same page. And there's many definitions of low value care, and depending on where you're reading, the definition will be slightly different. But there's some consistencies across the literature where low value care can be described as care that provides little or no benefit to a patient or a group of patients. Care that is low value may cause harm, or the risk of harm may disproportionately exceed the proportional potential benefit. And further, the additional cost of providing ineffective care does not provide the added benefit to the patient or health service. I like the Kirk et al. Definition, especially for nursing and allied health, as I think it's a bit more inclusive of all healthcare. You'll find I use the word patient quite a lot, and it's quite common in the nursing literature, but I know in allied health we use client quite a lot. But so you could substitute the word client for patient here. So Kirk defined low value care as care that is unlikely to benefit the patient given the harm, cost, available alternatives, or preferences of the patient. I think there are a couple of things that stand out here. Initially, when I thought about low value care, I thought about practices that are very clearly effective and clearly ineffective, and not so much about the emerging alternatives. And I think this is really difficult stuff, as it challenges us to think about things that were once evidence-based or habitual, and now there's evidence to say there's better alternatives. And I say it's quite difficult because when I first started my PhD, I was lucky enough to be part of a health research fellowship where I had access to quite experienced professors. And I remember one said to me, he was like, oh, it's tough when you're researching low value care, as you're going to be going up against people's life work, and they might be really clever people. However, for us as clinicians, we want to be keeping up with the evidence, and where there's evidence of better alternatives, we need to be adopting them as quickly as possible. The other key term to be across for this is de-implementation. In the healthcare context, it is defined as the abandonment of medical practices or interventions that have been found to be ineffective and harmful. And you'll find as the literature is emerging that many of the definitions are medical centric and less attention has been paid to nursing and allied health. However, I think this just represents a greater opportunity to pave the way when researching this area. And I just wanted to show you this slide. So you can see that low value care is not so black and white. And I think I use this diagram from Brownlee et al. In every single presentation I ever create. Ultimately, low value care can be considered across a continuum, with there being clearly effective services and procedures such as insulin for type 1 diabetes, or clearly ineffective services such as prescribing antibiotics without identification of a bacterial infection. And as I said before, services that were once deemed to be beneficial might change as more efficient services come through. And when I say that services, I'm talking about treatments, interventions. It's just what it was called in the literature as services. But I think it's why it's important to do research into these grey zone services and then how to stop them, how to clearly stop these ineffective services. And in nursing and allied health, as we're less developed science compared to medicine, our interventions often fall in these grey zones where they're less researched. And I've just put in here from this lecture series, I saw a few of the things. There's the routine hand splinting and then BOBA. So last week, the routine hand splinting, it seemed like a clearly ineffective service. And then the up and coming lecture, the BOBAth, is somewhere falling in the grey zone. And I might pause there to see if Annie has any comments on that, or if it's correctly placed.
Yeah, I mean, we'll have discussions next week about this, but the UK and Ireland guidelines are clearly saying to use alternative treatments to BOBAth, because the outcomes are going to be better for both walking, particularly walking, and also for upper limb training when task-specific training is used compared with BOBAth. So,
and then that's in most settings or post-stroke.
That's specifically for people with stroke.
Yeah.
So it's a treatment that's used for children with cerebral palsy and other neurological conditions. But the reviews that we'll be talking about next week are specifically about people who've had a stroke receiving the treatment.
Yeah. So hopefully, yeah. So that might even be able to go right across into the clearly ineffective section for post-stroke, if that's what the current literature.
Well, that's an interesting point, because in the studies that I think there's 13 to 18 trials in each of the systematic reviews, and it's really looking at the difference in outcomes. So people did improve with the both treatments, BOBAth and task-specific training, but the outcomes were superior when people had task-specific training.
Right. So that yes, so it might be in that grey zone of there's more effective or there's alternative treatments.
And the other thing that I think is also useful to think about for next week's talk is that none of the trials that we looked at had compared the BOBAth therapy with no intervention at all. Whereas in the splinting trials, we do have groups that didn't receive any treatment. So you're able to say, there wasn't any difference between no treatment and the hand splint, or it was so small to be equivalent to a measurement error.
Right.
We don't have that in the BOBAth therapy area. There's not trials comparing it with nothing. In fact, it's usually used as the conventional or standard treatment in a lot of the trials.
That probably links to my next slide quite well. So a bit of background on low value care, and you can see that first dot point, it does take 17 years to move research into practice. And you might have heard about the knowledge to practice gap. And that 17 years is a rough time. There's been many studies that have replicated this. I've seen 16, 17, 18, but 17 is the most consistent across the literature. implementation science attempts to reduce this gap between knowledge and practice. And in healthcare setting, these low value practices can account for 30% of all practices, which is a huge cost. And one study suggests that spending on low value practices was 10 to 20% of all healthcare spending, which is huge. Which is why it's important to understand these low value issues and then use implementation and de-implementation science methods to reduce the time it takes to move them into and out of practice. So in order to reduce these practices, it's important to understand why low value practices continue and what's driving them. There's no one answer, with drivers being usually multifactorial. And there's a great book that was only released at the end of the last year, and I think I've got it just here. It's How to Reduce Overuse in Healthcare, a practical guide, and I put it in the resources, so I'll pause the resources at the end and show you. But Cole et al. Suggests that drivers come from different areas. So healthcare professionals, patients, the clinical care context, healthcare organization, and the healthcare system. And I'll explain what I mean by each of them. So healthcare professional factors are about a lack of knowledge of the current evidence or being aware of the research of the effectiveness and alternate treatments. Also, healthcare professionals make incorrect assumptions about clients' preferences and expectations, resulting in unnecessary treatment. Example from Choosing Wisely, one of the recommendations for physiotherapy is do not provide manual therapy for patients with adhesive capsulitis of the shoulder. In this example, healthcare professionals might assume that a client has expectation for manual therapy, and therefore get the manual therapy. To get around this, healthcare professionals need to discuss the lack of benefits and harms with the client. The next driver is patients or our clients. So they're increasingly informed and empowered about different treatment options, and rightly so. They should be more informed and empowered, and I think things are going in the right direction, but they can also come in with knowledge from the internet, social media, and have and expect more than what can be achieved. There can be expectation to receive something, and they value getting a test or a treatment when no test as an alternative gains the same results. A simple example of this is when I was working in hematology as a nurse. I had a patient come in, and she had a friend who had a breast cancer chemotherapy, and she wanted the same one, but she had a leukemia. So she was just like, she was informed, but she was informed about the wrong treatment. And it's consistent across nursing and allied health. Going back to that hand splinting, if someone came in and seen someone else get a hand splint and wanted to have a hand splint, they might come in thinking, this is what I need, and I will value having my hand splinted over not having it splinted, even if the results are the exact same. The clinical care context. So the clinical context factors are the team that you work within or the leadership around you that can drive low value care. So the social context drives and promotes certain behaviors where you're more likely to perform a behavior if someone in your environment is doing the same. Example of this is the routine use of bow bath in stroke survivors, where if other physios might be doing the same practice, you're more likely to be doing that practice, even if there is evidence that suggests that task-specific practice produces better outcomes. Healthcare organizational factors are factors where professionals work, such as organizational policies and procedures. And we know that the policies and procedures might not always be aligned with the evidence. And then the healthcare system factors, system drivers, are those from the system level. So such as like a fee for service reimbursement, or which creates a financial incentive to deliver low value care. And I'd be interested, I can't really see any of the participants or the chat, but I'd be interested to see in the chat or any comments about drivers that people have seen in their practice. And I wondered if you had any comments about that, Annie.
Well, I think that the clinical care talk context, which is really what we look at when we're looking at barriers and enablers in the health service, certainly social influences from other practitioners and champions who perhaps might have been teaching at university or who run workshops. People like myself could be a social influencer in the right direction or the wrong direction, depending on what I teach. And I guess also in the healthcare organization, the leave options that people have to attend workshops. That's also part of the driver of, people are given, a lot of, I think the BOBAth workshops can be up to 3 weeks in duration, not all at one time, which is a significant amount of annual leave and cost for a health service. So sometimes it might mean that managers have to change some of their what they approve for continuing education.
Yeah, and I suppose if you had invested 3 weeks of teaching and learning, you'd probably want to use it in your practice, so it might be a difficult thing to give up.
Yeah. And, I worked in universities for many years, and, if you've been teaching a particular skill or a particular technique for a long time, and you've done research in it, you have a lot of investment as a health professional in that area.
I just wanted to put this in because you've heard a lot of me talking, and the best part of my week was making a meme specific to allied health. It was my highest motivation of the week, and also because I'm about to start talking about theories, models, and frameworks, which is a bit drier. So when thinking of de-implementing a low-value practice or questioning a practice that is, it is good to build theory into this practice. There was a really good scoping review by Nielsen et al. That searched for theories, models, and frameworks for de-implementation. And there were 5 found in this review that were developed for de-implementation, and another 5 found built from existing theories. But as this is a relatively new area of inquiry, there's not as many for de-implementing as there are for something such as implementing. And most of the theories from this scoping review suggested a multi-level understanding of the de-implementation process. And there was suggestion that implementation evidence can be used to inform de-implementation research. However, it shouldn't be taken for granted and transferred across the 2 sciences so easily. And I won't go into these theories too much because I'm going to go into one in a little bit more detail in the next slide. But as you can see from this table, there's the theoretical framework, the synthesis model for the process of de-adoption, framework for the organization-wide approach to disinvestment in the local health setting, framework for understanding and reducing overuse, and the taking action and overuse framework. And there's a combination of process and theory and models. But
Jake, can I ask you about the term disinvestment? Is it the same as, I know in the UK they talk about commissioners who can buy particular services or treatments for their trust, and I guess they can also decommission them and not fund them. Is this disinvestment similar or different?
It's used in the literature, it is used similarly to de-implementation. So if a organization is disinvesting in a certain practice, they can be sometimes used interchangeably. And then there's a lot of other terms for de-implementing, like de-adoption and disinvestment. So they kind of get used in place of each other. So it might be more of a organizational stance. So if, for example, a hospital wants to stop doing a certain practice, it might be called a disinvestment. But if it's more led by the clinician, is it a de-implementation? I think from the literature, what I've read is it does get used interchangeably.
I remember one of my colleagues in the UK a few years ago saying that they were concerned that their use of electrical stimulation was going to be affected by funding because it wasn't in the guidelines at that point as a recommended treatment, but it is now. It has changed. So there might be some therapists from the UK who'd like to put some comments in the Q&A about whether there has been any decommissioning of any treatment since the stroke guidelines last year in the UK.
Yeah, I'd love to hear it.
The other comment I was going to make is I used to give theories and models a very wide berth until I had to use them in my own research. And anybody who's enrolled in a master's research degree or a PhD will generally have to have some kind of a framework or theory to guide their research project. And they can be very helpful for giving you a framework to think about a particular problem or to think about what solutions you have available.
Yeah, I couldn't agree more, because I'm probably so deep in it at the moment. Some of them are quite dry and hard to grasp, but I think the ones that make sense, it does make your thinking about the whole process easier. So if you can use a theory or a model or a framework, I think it's definitely worth using. And I think the words themselves are a bit more scary than they actually are. And as I said, I find them hard to grasp. And there's one that I have chosen to go in a little bit more detail with, because it's the one that I found made the most sense to me and made sense the quickest. So the Grimshaw et al. Choosing Wisely de-implementation framework, I think it clearly steps through the de-implementation process. And you can see from the exemplar graph here, it is quite slick looking. So phase 0 is the identification of potential areas of low value care. And then phase 1, it steps through, is identifying local priorities for implementation of a recommendation or which low value practice to focus on. I think it's important as health professionals because we want to fix everything and do it all at once, but it's not feasible to do it all. If you start looking into low value practices, you'll see that there's too many to fix. Phase 2 is identifying barriers and enablers to implement interventions to overcome. And these could be barriers or drivers of low value care, like I mentioned before. In phase 2, they suggest using behavior theories to investigate the mediators and moderators of these low value practices. Phase 3 is the evaluation to see how it worked. They suggest using a cluster randomized control, which is a method used, or a well-designed quasi-experimental when evaluating the program, which is why you might see RCTs or cluster RCTs or quasi-experimental used in the de-implementation research. It is important for more of the science of it, as it generates knowledge about the effects of programs or interventions. And phase 4 is the sustain and spread of effective interventions. So if something's working in one clinic or hospital, then you want to see if it can work or spread into a similar clinic. And so in this example, they use preoperative testing, and I think this exemplar is quite good as it steps through the process quite systematically and rigorously. You can see quite nicely how one of the recommendations, and you might not be able to see it because the screen's too small, but one of the recommendations is don't order ECGs, and then as a don't order baseline ECGs. And it goes through the phases where they've identified 3 modifiable barriers, and then they have put interventions in and tested the intervention with a plan to upscale and spread. So I think it's not a very long article. It's a really good one to read, or a good place to go. I just thought I'd include this. It's kind of where to begin, and there's many good resources out there, but probably the widest known group would be the International Choosing Wisely initiative. And they've put out recommendations to improve quality and safety. And I pulled this from the Australian website, and it was targeted at consumers, but I think the questions that they get you to ask, it really holds up. And also I've used it to drive my own practice. So the questions that it says, I really need this test or treatment? Or if you're a clinician, do I need to give this treatment or test? What are the risks? Are there simpler, safer options? What happens if I don't do anything? What are the costs? And I think it's really important to ask yourself these questions in your practice. If you go into the Choosing Wisely website, it's very limited for nursing and allied health with their recommendations. However, the resources are there, and it doesn't mean that nursing and allied health do less low value practices. I think it's just more under-researched.
Yeah, and it might be in the next 5 to 10 years, we'll have an equivalent version in Choosing Wisely for different areas of allied health and nursing.
Yes, and that is something that is on the website now. Is you can see it's all nursing is branched into one group, and then all physiotherapy is branched into one group. And within medicine, there's the different arms of medicine. So I think we've got a bit of work to do, but I think it's exciting time if you're interested in this, which you are if you're here. And this slide here is just some of the resources that I have found to be the best. So I'll just quickly step through. That's the Grimshaw Choosing Wisely framework, that red one. That diagrams from the Brownlee article, which is the green one. How to Reduce Overuse in Healthcare is that book. It's quite a small book, and it's written for the clinician. I put the international Choosing Wisely's just to show that it's both Australia, UK. It's all across the globe. I didn't have enough to put everyone in. And then YouTube's been my biggest friend to break down some of these topics. And then I'll just leave this up if anyone wants to take a photo of the references or any questions in the chat.
Yeah, we haven't got any questions or comments yet, but while we're waiting, I might ask you to tell us a little bit about how this applies in your PhD area, which is pressure care management, because a lot of the occupational therapists will be interested in pressure care, I think.
Yeah, so my PhD in particular is on low value practice around pressure injury prevention in acute health services. And it probably started with me just thinking, why are we doing all this stuff? Is it make sense to be doing as much, or are we giving too much to patients? So the example that I'm going to use is for pressure injury prevention in acute settings, there's these preventative dressings that can be used indiscriminately. Sorry, I just got the vacuum cleaner right next.
Oh yes, Jake mentioned the cleaners might be coming.
Sorry, I'll get a bit of a break. So there's dressings that can be used to prevent pressure sores, and there's evidence from intensive care units that these dressings are used. And the intensive care unit is not the exact same as a mobile ward patient, but the practice is it's filtered through, and that was kind of what started my questioning of the practice. Like, would it be the same if we didn't do anything, and what's happening because of us doing these dressings? And there's lots of reasons that dressings are cheap, and not cheap, they're expensive, but they're quick and you can just whack them straight on. And I was questioning, there's environmental and there's hospital costs and patient costs. So that's kind of what sparked my interest in the whole area. And then so the idea for me is to do a review of the literature and looking at what's working for pressure injury prevention for organizations, and then talking to clinicians and seeing where this practice has come from and why it's been sustained. And then the plan will be to create an intervention and test it out.
So what kind of dressings are typically used? Is it on people's heels, or where?
Yeah, so the high risk sites, which would be the sacrum, hip, heels, and elbows. So they're the areas that, and clinicians always usually do practices because they think they're helping and they want to do the best by patients. But unfortunately, sometimes we don't have all the knowledge.
The other thing that it makes me think about too is that there's now, I think, something like 7% of the carbon emissions are from hospital waste nowadays. So the more bandages, the more dressings, the more packaging that's used, the more we're adding to landfill and to carbon emissions in hospitals.
Yeah, it is. And I think it's becoming more popular, and it's going to become more of a thing for hospitals to be graded against how much waste they are producing.
Yeah. The topic of splinting actually arose. I mentioned last week that Natasha Lanham, when she started doing her 2 trials for a PhD, that arose as a question from a physiotherapy colleague who said, "Do you think these make any difference to anything?" And so she started exploring, found there wasn't much research, and embarked on her first randomized controlled trial. And we genuinely thought it did make a difference, but it hadn't been tested. And so it was a big surprise to find that in the first trial, it made no difference compared with not wearing a splint. And in the second trial, with an even more extensive wrist position, again, still no difference. So not only did it really challenge our views about a treatment that we had a strong role identity and association with as occupational therapists, but it also made us think about all the resources, the time, 2 or 3 hours to make a splint, unless you're very efficient, and the cost of all the materials and obviously landfill that arises from it as well.
Yeah, and there's so many things that, as I mentioned, that drive us to do these things. I think patients coming into a GP wanting, got a cough and they need antibiotics. It's so much easier to say, have these antibiotics, than say, let's not have any.
Now, Lauren's got a couple of comments there for you.
Yeah.
Can you see them in the?
Yeah.
Read them if you want to read them out for the benefit of the recording.
So one of the questions is, are the strategies used for de-implementation similar to those used to change practice in implementation, e.g. audit feedback, use of champions, or do we need to do things differently, e.g. thinking about substitution strategies to give people an alternative? It's a really good question. There's clearly they're clearly ineffective practices we need to kind of pull out directly. And my view on that is there's never a pure de-implementation where you just stop doing something. There's always a substitution. And I think if you think about educating a patient as a substitution practice, I think it makes sense. The literature on implementation is quite large, and it's so much larger than the de-implementation literature. So as one of those references that I mentioned today said, you can use some of the practice change strategies, but they say just use them cautiously because they don't work exactly the same when stopping or halting or replacing something than starting something new. And then there's another question there. Often I think as clinicians, we worry about what will happen if I do nothing. And if we don't have high quality evidence for alternatives. And that is very true. It's the whole more is better mentality. And there's as clinicians and nurses and allied health staff, we're trained in action. We're trained to do something about something. So if X happens, we need to do Y. And it's really hard for us to do less. So sitting back and doing nothing is hard for us. But I think if you think about things, say, for example, giving an unnecessary treatment, are you wasting hospital resources that could be better put into a more effective treatment? I think that's the best way that I kind of got around it, because I think it's better to do more, and I was trained to do more, but I think it's you have to think about the time waste that we could be actually providing a service for a patient that, or a hospital that is more effective. What do you think, Annie?
Yeah, we had a bit of a discussion last week about that, when people come in with a very tight hand, and the expectation often from the doctor or somebody who's referred the person is that, they'll get botulinum toxin and they'll get a splint and then they'll be able to open their hand. And for some people, that's not going to happen. And some people, aren't able to participate in, several weeks of therapy that will require, multiple visits and practice and training at the same time that they're doing the treatments. So yeah, sometimes not doing very much is the best option in those cases, or there's a less expensive commercial option that they can buy, and the person can use that to keep their hand from skin breaking down if their fingers are crawling into their hand. And another example I can think of from a few years ago was talking to an OT and a physiotherapist in Europe who worked in a nursing home or an aged care facility. It wasn't an aged care facility, it was a home for people with traumatic brain injury who were in persistent vegetative state. Often they were either lying down or they were in a reclining chair for most of the day and didn't have much communication, if any. And they were at a workshop to learn about upper limb training, and we talked about, well, sometimes if you've tried all the different evidence-based treatments and there is no change and the person can't participate and respond, you do have to think about how you use your time if you're there employed on a full-time basis as an occupational therapist. What is the best use of your time to enable this person and their family who visit to spend time together? Maybe it's not the traditional therapies that you're used to using.
Yes, and I think I was thinking of an article that I read. It's consistent across the literature, Lauren, is the more is better, and it's harder for us to make subtracting changes than it is to implement a new change. So implementing is easier than de-implementing, or easier for clinicians to tolerate than de-implementing. There's a few good psychology experiments where people find it easier to give something to implement rather than de-implement.
Yeah, taking something away is difficult. That's why the word abandonment was a bit shocking to me when I first read the definitions. And some of my colleagues said, maybe you shouldn't talk about abandoning, treatment, but that's what the definitions talk about.
Yeah.
There's another question from Emma. Any tips on communicating de-implementation of therapy to patients, clients, and their families, particularly if they really are set on a treatment?
I think it's a communication workshop. Like, it could be its own thing. I think just using plain language and getting across the message that if they have a treatment that's ineffective, that it's not going to do anything, or it depends on what the treatment is. There's obviously a lot of low value care can cause harm, and the indirect harms, it can be hard to talk to a patient about how doing this one practice might harm the organization because we're not going to have as much money to spend on other things. It can be hard for a patient to understand that, but there's simpler things where patients don't if they don't need something, then they shouldn't have it. I don't know if that's a great answer, Emma, but it's communication is one of the hardest things to do in healthcare, I think.
I think that example you gave before of one of the choosing wisely topics is not prescribing antibiotics when somebody's not going to benefit from them, but they come along to see their GP expecting it. I think most of us will have been in that circumstance at some point, either ourselves or with our families, where we thought that was what was needed, and sometimes it's not. So, how do you help somebody come to terms with the fact that it's not an effective treatment, it's a waste of time, and in fact it could be harmful for them to have more drugs in their body that could reduce their effectiveness in the future?
And I've read a couple of trials that had predetermined scripts, and that is part of a de-implementation strategy of to have an answer, like a simple scripted answer for if someone needs wanting or requesting a treatment that is low value.
Yeah, I mean, I think in the treatments that we're going to be talking about next week, ball bath, but also hand splinting, I think that would be very helpful for lots of clinicians to actually see a video or a couple of videos of people talking through what they've done to change their practice, or what they say to other therapists who find it very difficult to change their practice. And I know in Denise O'Connor in Melbourne, her research has been around general practitioners and helping them to change what they do when they're seeing people with low back pain. And they use scripts to give to GPs so that there's certain things that they would say in response to the questions and the comments that came from patients. So maybe that's part of what we need to help therapists and services to change their practice.
And as I said, it's not easy as well. It's like antimicrobial stewardship, which is antibiotics being given wrong and used inappropriately from all people, is such a huge area. So it's not a really easy area to stop doing a practice or yeah.
Shay's asking about whether there's any research about de-implementation of low-value processes rather than actual treatments.
I think you could probably just use a lot of the low value interventions or low value care. It's care, the term care could be about processes. I think a lot of the low value care literature would be relevant to processes. It depends what the process is. Do you have any more?
I don't know, Shay, if you'd like to be more specific about what kind of process you're thinking about. Usually with a process, you have to define what somebody's doing, and that becomes the intervention. So yeah, when we talk about pathways, there's certain things that you do as part of clinical pathways or processes. Yeah, I can't think of any examples. Oh, so you're talking about a stroke pathway, yeah. So that's steps in what you might do when somebody's admitted, or when they have a particular, if they have a very weak arm, or they can't sit or they can't stand, there's certain processes that would be followed to, I guess in nursing you would have similar processes too.
Yeah, and I wonder if that would be sort of an intervention, that process, like if you were to measure the process of coming into the hospital or coming into the clinic and getting all these measurements, is that an intervention?
Yeah. I mean, we often talk in our workshops at StrokeEd about the fact that, the doctor will do a manual muscle test often of the person. The physiotherapist might do a manual muscle test. The occupational therapist will do the same thing. And that's taking up valuable time and not really giving us a lot of information about what the person can do. But I don't think there is any research, Shay, on that as a process. But it's a very good question that you ask. How we use our time as a team.
And that, it might be related to some of the over treatment. So if that example you just gave, Annie, of all that multidisciplinary group doing the same thing, is that an over treatment, which is, it comes up in the literature quite a lot.
Yeah. Let's see, anything else there? There's no problem with us finishing a little bit early, because that will mean the recording will be a little bit shorter for people to listen to. We've got another question there from Kayla. Is there much evidence around low value care in the private sector? Private health insurers currently require therapists to fulfill certain amounts of hours or types of therapies for clients, favoring quantity over quantity of therapy interventions. Yeah, good point, Kayla.
Yeah, I have to admit, Kayla, I'm working in the public sector, so I'm kind of quite deep in the public literature, but I think it would definitely be in the drivers of this is what's driving the low value practice.
Mm.
I haven't looked too much into that area. I don't know if you have any.
Well, when I did my first implementation trial was trying to get OTs and physios to actually take people in the outpatient and community settings out of the building and do more community ambulation and travel training and transport training with people. And I had 4 or 5 of the 24 sites that were private hospitals in New South Wales. And I can remember one private hospital where the physiotherapist had to see 18 patients a day, which is a lot. It's somebody every half an hour. This is a neurological rehabilitation hospital. And so that was a major barrier to them being able to go out, because by the time they sort of said hello and got the person up and walking, there wasn't much time left to get outside the hospital doors and do very much on curbs or crossing roads. So that funding model certainly can be a barrier to some of the practice change.
And I think that's why it's probably very important to be researching in this area, is so we can make more knowledge more available to systems, so like government, that can make changes to funding. It looks like it's a funding issue.
Yeah, and I think it very much depends. This is why we need brave allied health directors and leaders in management to say this is what the evidence says we should be doing, and that this is not a treatment that we should be encouraging therapists to use. And so this is the way that we're going to be. This is our clinical pathway for these reasons. So they take up that discussion with senior management and the hospital management board. Okay, I think that's about it. We can finish a little bit early. Thanks everybody for joining us from wherever you've been, and hopefully you'll come and join us next week. We have 2 lectures, 2 evenings in a row. The first about ball bath therapy, and I know that's going to interest quite a few therapists. And then the following evening or morning, we have Rachel Stockley, Dan Eves, and Sarah Moore talking about how to do mental practice as an alternative treatment or an additional treatment for those of you who work in stroke rehabilitation. So thank you very much for your explanation of de-implementation, and hopefully we've given people a bit more of an idea of what they might do in this area. And I'll just stop the recording now.
Yeah.